Welcome everyone. This is Miss Sheridan from GNTC Floyd County Campus, and today we'll be doing your lecture on Chapter 20, Admission, Transfer, and Discharge. These next two slides just cover some basic terminologies that is covered in this chapter, so make sure you familiarize yourself with them. We will be discussing these as we go through the slideshow. As a nurse, you have the opportunity and responsibility to make the admission process less stressful for your patients and their loved ones. It is during the admission process that you as the nurse will make your first impression on the patient. This first impression is crucial. It is one that can either help improve your patient's stay or make it a negative experience. And once it becomes a negative experience, it's hard to come back from that. It sets the tone for the patient's stay. So you want to strive to set a positive tone. Walk into the room with a smile on your face. Avoid letting unpleasantries like being short-handed or behind schedule show in your speech, your facial expression, or your body language. The patient does not need to know how busy you are or how badly your day is going. Your admission process is that time where the nurse is establishing trust and rapport with the patient and the family. There are different ways a patient can be admitted. A patient can be admitted from the physician's office as a direct admit to the hospital. When the patient is being admitted from a physician's office, the doctor will contact the hospital and speak with the hospitalist, which is a general hospital doctor. If the physician has hospital privileges, then he or she will write doctor's orders for the hospital nurses so they can go ahead and start the admission process. A direct admission can vary from hospital to hospital, so it's important to contact the hospital for more info. If the nurse is receiving or giving information regarding a transfer, it's important to document the name of the nurse the information was taken from or given to. The nurse will inform the patient of the transfer and calm any fears that they have. And it's also possible to get admitted to the hospital the traditional route, through the ER. And after the ER docs do their assessment and deem that admission is necessary, they will find a hospital bed for them and they get admitted that way. So just remember, the admission process is that time for rapport and to build a trusting relationship. Make sure when you introduce yourself, you include your credentials so that your patient will know whether you are a registered nurse, the licensed practical nurse, a student nurse, or someone from another department. Shake the patient's hand. That provides a form of physical contact that is not threatening or demeaning, and it exhibits a welcoming approach. Make sure you make eye contact with your patient and speak at a rate that does not sound hurried. You can also pull up a chair and sit down. Speak to your patient on an eye level. Address the patient by his or her surname, such as Mr. or Mrs. Stevens. Avoid the use of first names unless the patient specifically asks you to do so. Avoid using terms of endearment such as honey and sweetie, as that is also often deemed unprofessional, and it can be considered rude to some people. So make sure during the admission you recognize it's their first impression of you and the facility, and you want to make it a positive one. Speak very kindly, respectfully. And remember, the patient is very nervous and concerned about having to be admitted, and your job is to make them feel as comfortable as possible. Let them know you're going to take great care of them and do the best you can to try to relieve the nervousness of the patient. And we'll talk about some tactics on how to do that during the slideshow. Now it covers common patient reactions to admission, the first one being fear of the unknown. This is a safety and security concern in our Maslow's hierarchy of needs that we introduced in Chapter 4. So the patient is going through all these questions they have in their head. What's wrong with me? What's going to be done to me? How long will I have to be here? Will there be any discomfort? Who are all these people coming in my room, and will I get better? Will I die? The fear of the unknown is probably one of the most common responses that your patients have when they get admitted to a facility. Fear of the unknown comes under safety and security in Maslow's hierarchy, so it can result in insecurity if the unknowns are not relieved in a timely manner. Nursing interventions for fear of the unknown. Introduce yourself, like I mentioned, and include your credentials. So, hi, I'm Mary. I'm your LPN going to be taking care of you today. Explain what he or she can expect. Be honest in all communication, even with children. You must be honest because if you are not, they will learn to distrust you. Tell the patient what you are about to do. I'm here to do your head-to-toe assessment today. Whatever it is you're about to do in the room, or are you there to give them their medications, etc. Ask if there are any questions or concerns you can address. The same thing goes with the family. Introduce yourself to them, explain things to them, tell them what you're about to do. Ask them if they have questions. For children, allow the parent or caregiver to hold the child. You want to physically get down to the child's level. You don't want to tower over them. You want to position yourself at eye level. Smile, talk softly and slowly. Allow the child to hold and become familiar with equipment, like allowing a child to take a tympanic temperature on a teddy bear, or listen to their mom's heartbeat with a stethoscope. That will make them much more comfortable. Another very common reaction to patient admission is anxiety. This is another safety and security concern in Maslow's hierarchy of needs. There are a lot of reasons why the patient may be anxious. They may be anxious because of their medical condition or an injury that brought them to the hospital. It may be anxiety over childcare concerns, who's going to watch their children, dependent family members, pets or animals. Remember, some individuals may not have a strong family support system or friends who live nearby. A common cause of anxiety related to admission to a hospital is financial concerns, expenses. How am I going to pay for this? Or if they have a lack of insurance. They might be worried about missing work, or the expense of hiring someone to care for their dependents at home. Anxiety can also develop due to separation from familiar surroundings and significant others. This is known as separation anxiety. Separation anxiety, so a different environment or not being around a loved one, common with children and older adults. And just keep it in the back of your mind that most individuals prefer to recover from an illness or an injury at home. They're more comfortable rather than having care provided to them by strangers in an unfamiliar clinical setting. And we'll talk about some nursing interventions on how to help all this anxiety on the next slide. So some nursing interventions on how to help your patient be less anxious. The most common way to decrease anxiety is to always explain who you are and what you're about to do before you do it. Encourage the patient and the family to ask questions. Make them feel comfortable to ask questions. Always avoid use of medical terminology and jargon. Use layman's terms. You never want to assume that adults know medical terminology unless you know it as a fact. Maybe your patient you know to be a doctor. Just an example. So it's important to remember that the lay person usually doesn't know what you mean when you tell him you're going to auscultate his lungs. This may sound very invasive or scary to the patient because you may not be familiar with medical terminology. The most common way to reduce the anxiety is to explain what you're doing before you do it. Even simple things like, I will be listening to your lungs. So when you do use medical jargon with adults, explain what those mean. Explain what the words mean in terms that they're going to understand. Never assume that they know medical terminology unless you know it as a fact. Another common response to being admitted is loss of control. And this is something also under safety security tier of Maslow's hierarchy of needs. There is a steady stream of individuals at the patient's bedside. You know, it can come from the laboratory, radiology, the business office. They could be interns, residents, they can be nurse assistants, registered nurses, a case manager, etc. They all ask numerous questions. Many of them are repeated questions by several individuals, leading the patients to complain of repetition. Surveys indicate that one of the most common patient complaints is lack of communication among healthcare workers. Effective communication by healthcare providers can prevent some of this question duplication. Pay attention to what has already been documented by others. So one thing we used to do where I used to work is I would go in when the doctor did their assessment, you know, and then once the doctor gets done, I know exactly what they've asked. And then I can finish asking all my questions and do my assessment, or vice versa. I've had doctors come in and watch me do a head-to-toe assessment, and then they continue with interviewing the patient afterwards. You know, you kind of work together and group all your care together. Same with working as a team with your CNAs. Try to communicate well together, and it'll work best for your patient's best interest. Some other reasons why the patient may feel a loss of control is having to share a room with another patient, if it's a semi-private room, sleeping in a different bed than they're used to, using a different bathroom, eating whatever food is provided regardless of how it was prepared or what time they're eating. You know, they're not going by their normal set schedule now. They have to go by the facility schedule for meals, for sleeping, for their meds or diagnostic tests. They're being awakened during the night for nursing care, being disturbed by normal hospital noises, and they're just not as independent as they are used to. A patient may feel a loss of control over attire, modesty, and privacy when admitted to the hospital, like being asked to wear a gown rather than their own personal pajamas. Whenever possible, allow the patient to wear their own pajamas, you know, that makes them more comfortable if they have a preference. Take care to protect the patient's modesty while assisting the patient to dress or undress. One thing to note is that your patient may view exposure of their body very differently than would a healthcare provider. You see these body parts every day, every shift, but it's not an everyday occurrence for patients to view and handle other people's bodies like it is for you, the healthcare worker. It's necessary for the patient to be modest. Allow them to wear their own pajamas when they can. You could allow them to wear a hospital gown on backwards so it keeps their backside covered. Always knock before entering. Allow the patient some independence to dress themselves as much as possible. Close the door or pull the privacy curtain, and use drapes and bath blankets. Only uncover the section of the body you are assessing or working with at that time. Patient rooms. So private rooms are more common, but it is still possible that a patient will have to share a room with a stranger in some facilities. Generally, the two patients not only share a room, but they also share bathroom facilities and are able to overhear each other's conversations with healthcare providers and families. These situations can cause undue stress and feelings of loss of control for the patient. So some nursing actions you can take is to pull a curtain between the beds. Try to maintain privacy as much as you can. Stand near the head of the bed while talking. Keep the volume of your voice low. Now, if you have anything sensitive to discuss with the patient, any sensitive information, any test results, things like that, the doctor or whoever's giving them those test results should take the patient to a private exam room to discuss that sensitive information. It should not be discussed here in the room where their roommate could overhear. Things you can do to help your patient who is feeling a loss of control are to allow the patient to make decisions whenever possible, even seemingly small ones. All of that is going to help. So let them make decisions like, do you prefer your drinks with or without a straw? Do you want your lights on or off, or do you want your door open, cracked, or closed? If you provide choices and let the patient feel that he or she maintains some control over the situation as much as possible. Loss of identity is another issue that can happen when being admitted to a hospital. Some patients feel a loss of identity when they're hospitalized, so it's very easy to see how it developed. They now have a room number, a patient number, a call light that they must use to obtain assistance. They are now one of many patients and are often forced to wait for what they might consider to be routine services, such as going to the bathroom or a test or procedure, getting their medicine, getting their lunch tray, linen changes, etc. And a lot of the care is focused on the treatment, the plan of care, but you don't want to lose your patient's sense of identity. Always remember, your patient is a human being, not just a room number, not just a diagnosis. They are a human being. Make it a priority to learn your patient's name quickly. Call them by Mr., Mrs., Miss, whatever's appropriate with their last name. Avoid using first names unless they ask you to do so, and some patients will. They just feel more comfortable with you calling them by their first name, and that's perfectly fine if they tell you to do so. Never refer to patients by a room number or a disease or a condition. Use their name. Explain to the patient why you're placing an identification band on their wrist. Make it a priority to use their name to strike up a conversation with him or her. Providing culturally competent care. So avoid the use of slang. Use common language. You always want to get a professional interpreter in cases of language barriers. Remember to not use a family member or a friend to translate. They're not neutral parties. They may have emotional and personal attachments. They're not professional interpreters with understanding of medical terminology. They might interpret incorrectly, and that could have serious consequences. Do not use ethnic dialect unless fluent in it. Use eye contact judiciously, because some cultures may find it disrespectful or a challenge to authority to look someone in the eye. Position yourself so the patient can read your face and your lips. Pay attention to your patient's facial expressions and body language. This can help you determine when the patient may not understand your communication. Respect their beliefs regarding healthcare, family, their religion. Clarify any information you might not understand. You never want to assume. This is just all the demographic patient info that's obtained at admission. And it's obtained by office staff, the full name, social security number, age, date of birth, residential address, telephone number, and next of kin name and contact. The office staff also obtains info regarding religious preference, their place of employment, insurance, physician's name, the reason why they're admitted, and whether or not they have an advance directive or a living will. Every facility has a form that has to be completed and signed that grants permission for treatment. If the patient is a minor, the authorization for treatment must be signed by a parent or a legal guardian. Now, there is one exception to the rule here, that it is legal for an individual younger than age 18 to sign authorization for treatment if they are an emancipated minor. The age in which an individual is no longer considered a minor differs from state to state. In most states, it's 18 years of age. The identification wristband stays on the patient through the entire hospitalization. This identification band is one of the methods used to identify the patient prior to any procedure or the administration of medications, for instance. Different color bands are used to indicate food and drug allergies, latex allergies, fall risk, and limb alert. The colors used may vary from state to state, although an allergy band may be bright red or yellow so that it could be easily noticed. The basic admission kit typically includes a water pitcher, drinking glass, wash basin, emesis basin, soap dish, box of tissues, and then you would provide a bedpan or a urinal if needed, provide assistance with needed with changing into a hospital gown, and provide privacy. The nurse is responsible for completing an inventory of clothing and personal items, such as glasses, contact lenses, dentures, and hearing aids. And those items may be kept at the bedside, but it's going to be noted on the personal belongings inventory form. Instruct the patient to send all valuables such as money, credit cards, jewelry, home with family members. So instruct them to send valuables like money, jewelry, credit cards, etc. home. If there is no family member available or the patient desires to keep valuables at the hospital, review with the patient the hospital's policy for storing valuables. Inventory the valuables and list them using only general descriptions. We'll discuss that on a later slide here. So belongings are personal items that can be kept at bedside, like dentures, glasses, contact lenses. So belongings can be kept at bedside. Valuables are like a wallet, money, jewelry, electronic devices, etc. Something with sentimental value. Valuables need to be locked up in a safe or brought back home by family. Upon admission to the unit, the nurse needs to make the patient aware that the hospital will not accept responsibility for items that are kept at the bedside. So this whole slide here is going to be important for you to know how to describe these personal items on the belonging form. Use general descriptions, and you're going to list all belongings. It may take you a while to fill this out. For example, you cannot with certainty tell by observing a ring, for example, that that ring is real gold or whether it's silver, platinum, diamond, or zirconium. Whatever you list on that inventory sheet is what the hospital is responsible for returning to the patient. It does not matter what subjective info the patient tells you. You only document objective data, what you can see with your own eyes and what you can state factually as the nurse. Only objective data. This is a good example. So rather than writing a 24-karat yellow gold ring with a 1-carat diamond, we're just going to write gold color ring with a clear stone. Remember, you can't go off of subjective data the patient tells you on an inventory sheet. You have to go by your objective findings, what you as the nurse can see with your senses and what you can state factually. And I can state that this is a gold color ring and a clear stone. You can't be sure that this is a yellow gold ring or a diamond or zirconium, etc. Make sure you document if the patient kept it at the bedside, if they placed it in a valuables envelope to be locked up, or if the family took it back home. So on that inventory sheet, you're not only describing the personal items, but you're also stating where they went. Are they at the bedside? Are they locked up? Or did it return back home with the family? You always, on admission, want to ensure no medications remain in the patient's room. Many patients bring their home meds to the hospital. You know, a lot of them do it so that the nurses can get an accurate record of what they're taking, but some of them still believe it's okay to continue taking their home medications while admitted in the hospital. Teach them that this is not the case and you'll be administering their medications for them at the hospital. And if they medicate themselves in their room, it could be very dangerous. Every facility's policy is different, so make sure you familiarize yourself with that. Per facility policy, those meds are typically locked up in a safe, usually in the pharmacy or in security, depending on the policy, but it is preferable to bring it back home with the family. You know, when working night shift at the hospital, I was working with a patient on a unit that had taken a narcotic she had hidden in her room. We didn't know she had medications hiding in her room, but I knew how much pain medicine I gave her, and it wasn't anywhere near what would cause her to become unarousable with respiratory depression. We searched her room and found she had a bunch of narcotics in her room that she, evidently had taken herself. So coupled together with what she was receiving in the hospital, it was way too much for her. She became unarousable, respiratory depression. We ended up having to give her some Narcan, which is that opiate antidote we mentioned in the previous chapter, and it counteracted all the narcotics she had taken. After Narcan, she woke up almost immediately, very agitated. Sometimes they wake up combative after having Narcan because it blocked the effects of the opioids. It reversed the overdose. So that's just an example why you would always want to make sure there's no medications in that patient's room. It could be very dangerous. I've also witnessed nurses accidentally leaving normal saline flush syringes in a patient's room, the syringes they use to flush their IVs out. And I've seen them leave needles in the room. I once witnessed a patient come clean about apparently having narcotics hidden in the room, and they've admitted to crushing up the pills and mixed it with normal saline from the flushes. So they diluted it in the normal saline, pulled it up in the syringe with the needle, and then proceeded to shoot it up in their vein that way. I had a patient come clean about that one time. I've seen some crazy things. Never leave any medications in the room, any syringes, any flushes, any needles, anything that could be potentially dangerous to your patient. Never let being in a rush, miss important things like this, like leaving medications and dangerous things. Some of these patients become very desperate. So it's important that there's no meds or unsafe medical supplies left in the room. Other info you're going to collect during admission is the patient's history of diseases and surgeries, family medical history, food, drug, seasonal, environmental allergies, and pertinent health habits like a special diet. Do they use sleep aids, tobacco, alcohol, recreational drugs, or laxatives? You're going to assess whether they're employed and the type of work, their level of consciousness, their orientation, their entire head-to-toe physical assessment on admission. You're going to obtain their current prescriptions, their over-the-counter meds, herbs, nutritional supplements, and illicit drugs. So it's not just their prescriptions, it's all these other things. Over-the-counter meds, herbs, nutritional supplements, and illicit drugs. So you have to prompt your patient here. You have to ask them for these things. Sometimes they're not going to just offer up the information. Sometimes even if you ask them, they won't offer up the information. You got to do the best you can to obtain your data. Now, if they don't have a list of their prescriptions with them or the pill bottles at bedside, best practice is to just find out what pharmacy that they use and call that pharmacy, and they can either fax you a list or tell you the list over the phone. Only thing I want to make sure I tell you is that a lot of patients use multiple pharmacies for multiple different reasons. So you just got to make sure you get a list of all the pharmacies you use so you don't miss any meds that they're currently taking. You're also obtaining data like the description of why the patient's being admitted in their own words, their personal inventory and valuables form that we covered previously. You're going to cluster your collected data from your patient interview questions and then proceed with your head-to-toe assessment. Vitals, height, weight, finger stick blood sugar, especially with diabetics, pain, discomfort, and then assess all of their body systems from head to toe. Admission orientation checklist. So when you are orienting the patient to the unit in their room, you're orienting them to the location of the nurse's station, how to use their call light and intercom system, and if you feel like they need to practice pressing the call light and then answering the call light, you can do that. Have them practice pressing the red button. Location of the bathroom, how to use the telephone, how to operate their bed, how to operate their lighting and television. You will orient your patient to the location of their personal care items. And normally there's a form or a note at the front of the patient's chart to remind whoever's discharging the patient to obtain those personal care items. And the patient will have to sign on discharge that, yes, I did receive all my personal care items back that were locked up, or my medications that were locked up. You can have medications locked up as well, like depending on the facility policy where they keep them. But if it's a narcotic, you have to have 2 nurses and count all the pills in that bottle, and then you both sign off on it. You're going to orient your patient to the times meals are served, the hours that you're going to be his or her nurse, any policies that might apply to them, and when the physician typically makes rounds on their unit. So once you collect your admission data, that's your assessment out of the ADPI. Now we're moving to the diagnosis stage of the nursing process, where we're compiling and analyzing data and identifying what the actual problems the patient has is, as well as the potential problems the patient is at risk for developing. Remember, discharge planning is initiated during the admission process. So you should never wait to initiate the discharge planning. You need to start on day 1 when the patient arrives to the facility. The primary goal when a patient is hospitalized is to keep the patient's stay in the hospital as short as possible without endangering the patient's health. Discharge planning that has been ongoing since admission helps to make the discharge process go very smoothly, and it also goes much quicker. The typical discharge process is that you first obtain a physician's order, so you must have a physician's order for discharge. You're going to notify the business office of the discharge, reconcile the patient's medications, and we'll talk about med reconciliation here later in the slideshow, but basically reconciling the meds means, does the physician want the medicines that they're on in the hospital to be continued or discontinued when they go home? We're going to provide discharge instructions, teaching, prescriptions, assist the patient to gather their personal belongings and valuables, help them pack up their room. Typical discharge process is documenting the patient's conditions, and that includes their vitals. Assist the patient to the car, document the time of discharge and the method of transportation. So are they being picked up by a family member? Are they going by taxi, etc.? Notifying housekeeping so the room can be cleaned, providing discharge instructions, and make sure our follow-up appointments are scheduled. Discharge planning begins during or shortly after admission to the hospital and continues until the patient is discharged. So our nurse's role in discharge planning is to teach about the patient's illness, dietary alterations, safe and effective use of meds, how to perform treatments, methods of adaptation when it comes to being at home, recommendations for various support groups. So you can see your role is not just to be a nurse, you're also a teacher for your patient and their family members and their caregivers. Nurses also provide the patient with a list of community resources if necessary. We help make referrals. You can help assist the family to find a long-term care or assisted living facility. And a lot of times that's done primarily by the social worker. Patients often receive new medications or have changes made to their existing meds at times of transitions in care. And that's upon hospital admission, upon transfer from one unit to another, or discharge from the hospital to a home or another facility. So this is where reconciliation of meds is super important. Every medication must be listed out. Every drug taken prior to hospitalization must be continued, discontinued, or the dosage must be changed by the physician. So it's either continued, discontinued, or it's changed in some way, it's modified. Look for duplication of drugs, generic versus trade names, and unintended multiples of drugs within the same class. Patients often have more than one physician providing care and writing medical orders. This can result in physicians writing orders for similar drugs or for drugs that are contraindicated, meaning they are not supposed to be administered together. It's not uncommon for the patient who has a primary care physician as well as one or more specialists to have the same or similar medications prescribed by more than one physician. With the use of generic names and multiple trade names, the patient most likely would not know that they were the same drug. So it is the nurse's responsibility to use caution when comparing the names of medications the patient is taking prior to admission, as well as comparing them to any new orders or dosage changes ordered at discharge. So we're going to check to make sure the dosages are correct and any differences or changes in the doses were intended. Look for any red flags, any dosages out of the typical range. Make sure prescriptions have been provided for new meds upon discharge, anything they were not originally taking at home. Make sure there's a written list of medications provided to the patient. So the goal of med reconciliation at discharge is to reconcile the medications the patient was taking prior to the admission and those initiated in the hospital with the medications they should be taking post-discharge to ensure all changes are intentional and that discrepancies are resolved prior to discharge. This is an example of a med reconciliation sheet, and this particular one is like a paper chart example. They do have this electronic on computers as well, and it looks very similar. Just depends on what program your facility uses to document. But basically, all the medications are listed out, and remember, it's not just prescription drugs, also over-the-counter and herbal meds. So first one, like Ambien, 10 milligrams by mouth at bedtime is needed. So on the form you have a C, D, C, and M. C stands for continue, D, C for discontinue, and M for modify. So if it's modify, the doctor will write what dose or what frequency, whatever it is they want to tweak, they will write that in or put a new order in for it. So they're going to tweak it slightly. So they just go down the list and do that for each individual medication. Discharge instructions. So we're going to teach when to return to the physician for follow-up, the list of their medications, how to take them, what they're for, what side effects to look out for. We're going to teach about their diet or activity level, signs and symptoms of worsening condition that warrant them to go be seen by a doctor or notify the doctor. After reviewing discharge instructions verbally, ask the patient or family if they have any questions and verify understanding of discharge teaching. You can have the patient or family return demonstrate a skill you've taught them if it's applicable. For example, changing a dressing on a wound. So you go in there and you show them how to change the dressing the first time. The next time the dressing needs to be done, you have the patient or the family member show you how to do it. So they're return demonstrating. Once they verbalize or demonstrate understanding, have them sign the discharge paperwork. You're going to put one copy of the discharge paperwork in the chart, give another copy to the patient to take home. And then you're going to make a nurse's note stating that the discharge instructions were given both verbally and in writing. Note if the patient return demonstrated a skill. Note the response to the instructions. Did they verbalize understanding? I also always documented, you have to walk them to their car and help them get in it, or at least delegate that to a CNA. And I would include that in your nurse's note, as well as a last set of vital signs you obtain on them, that they were stable and that they had all of their belongings. So normally a discharge order is written, but sometimes a patient might become unhappy with their care, or just decides against treatment for whatever reason, simply decides to leave the hospital before the physician authorizes a discharge. This is known as leaving against medical advice, or leaving AMA. One thing to teach your patients is that many insurance companies may not pay for the patient's care if the patient leaves AMA. The patient should be warned of this. If the patient decides to leave AMA, your responsibility as the nurse is to attempt to reason with him or her and explain why it is not in his or her best interest to leave without authorization of the physician. If that fails to convince the patient to stay, you will ask the patient to sign a leaving AMA form, which releases the hospital and physician from responsibility for the patient's health status after he or she leaves. If the patient refuses to sign the leaving AMA form, document in the nurse's notes that the form was offered, but the patient refused to sign it. Most facilities require you to notify the attending physician regarding the situation. So whenever the patient is requesting to leave AMA, I always try to reason with them, explain why it would be in their best interest to stay, and notify their physician. Some physicians, if they have time, will come up and speak to the patient. Otherwise, you just get them to sign that leaving AMA form, and if they refuse, just document that they refuse to sign it and make a good nurse's note. Notify your physician and your charge nurse. So when a patient threatens to leave AMA, bye Felicia. As soon as you're aware of an impending discharge, notify the business office so that the records can be assessed for completeness. They get everything ready. If the patient has health insurance, they have a form that authorizes the release of information to the insurance company. So that gets signed by the patient. And then it allows time to complete necessary paperwork before the patient is ready to leave. So you want to assist your patient to gather their personal belongings together, and you can definitely delegate that to your CNA or help them pack up their room. Maybe you go get the things that are locked up, if they have anything locked up, and the CNA helps them pack up their room. Make sure any assistive devices have any eyeglasses, hearing aids, and dentures, all their valuables, etc. Make sure if the patient has valuables locked in the hospital safe that you obtain them, and typically there's a form that they sign saying that they've received them back. And that goes the same with any medications that might be locked up. So you have to have the patient sign the form for the receipt of the valuables and then sign the form yourself. You're going to discontinue any equipment, tubes, IV sites, etc. per MD order prior to discharge. Assess their vital signs and document. So you always get a set of vital signs before they leave. Address any questions or concerns. You make sure their discharge paperwork is completed. Document your nurse's note, noting the date, the time of discharge, the method of transportation. Also, they received your discharge teaching, they verbalized understanding, vitals were stable, and they left via car. Maybe a family member picked them up or so. Then you'll notify housekeeping to clean the room. So sometimes the patient may need to be transferred. They may need to be transferred to a higher or lower level of care. An improvement or deterioration in the patient's condition may necessitate transferring a patient from one unit to another within the same facility, or from the hospital to another facility, such as a long-term care facility or specialty hospital. A transfer from the hospital to another facility includes completion of discharge as well as transfer papers. So if they are going to another facility, let's say long-term care or a specialty hospital, you have to do all the discharge paperwork as well as transfer papers. The simplest transfer is the transfer of a patient from one unit to another within the same facility. To complete this type of transfer, you need to obtain a physician's order, explain the reason for the transfer to the patient and the family. Always, when your patient is being moved to a different room or a different facility, or they're being discharged, you need to notify their family. You're going to reconcile the list of patient medications. So you do a med reconciliation just like you do with a discharge. You're going to gather the patient's belongings, supplies, their chart. Complete the transfer summary form per your facility. You're going to call report to the patient's new nurse. Transfer the patient with belongings and document the time of transfer. When you transfer to another facility, you're going to do all the steps that were outlined on the previous slide, transfer within a facility, plus completion of a transfer and discharge summary. So you have to do the discharge paperwork. Provision of doctor's orders for the new facility. Notify the family. Arrange for transportation as needed, such as EMS. Ensuring the transfer of confidential medical records, and that the records are received by the proper medical personnel at the new facility. Typically how it works is they have to get the chart first, and then once they get the chart and they're able to review it, the nurse can call report to the new nurse. Discharge planning is all about teamwork. It's multidisciplinary. It's a collaborative team effort, involves all disciplines like your physical therapist, speech therapist, dietitian, social worker, wound care nurse, physician. So generally the nurse is the specified discharge planner that's coordinating the process, but it does involve the healthcare team. So you have to work together to develop a plan that meets all the patient's needs after discharge. This brings us to the end of the chapter, and we have a few review questions here. When caring for a hospitalized child, the nurse should never tell a child that a procedure will cause him or her pain. True or false? Well, first of all, we got an absolute word, never. Anytime you see never, always, it's generally incorrect. So the answer here is false. The nurse should tell a patient that a procedure will hurt if it's the truth. You need to be honest with them. Describe what will be done to decrease the comfort. You always want to be honest. It's the best policy. It helps establish trust and rapport with that child. Which of the following is an appropriate guideline for providing culturally competent care? So let's see, call patients by their first name. We talked about how that wasn't the best practice unless they specifically tell you to do so. Do not use ethnic language unless fluent in it. That seems like it might be correct. I'm going to hold on to that one. C, use correct medical terms whenever possible. We talked about how we should avoid using medical terms unless the patient knows the term, but we need to use simple layman's terms, not medical terminology. Keep eye contact with patients at all times. That's not the best answer because eye contact should be used judiciously and according to the patient's cultural view. So the best answer here is B. Do not use ethnic language unless fluent in it. Discharge planning should be initiated during the admission process. If you remember when we spoke about discharge planning, we said it needed to be started early during the admission process, so that is true. It requires a lot of team effort, so the nurse should initiate it during the admission process. The nurse should collect data regarding the patient's living arrangements, physical limitations, and the ability to perform activities of daily living that might impact the patient upon discharge.